Welcome to the weekly Independent Sage briefing. The first week of September heralds a new academic year and signifies the return to work for many after the summer break. But with more than 30,000 new cases per day this week, there's understandably some concern about what the supposed return to normality might actually entail. Today, we'll be presenting 3 reports which give advice on how to remain safe if you are soon to be in a position where you're exposed to a lot of people. And first, we're going to go to Professor Christina Pargel, who is not going to start with facts and figures, but instead she's going to be presenting the updated reports on schools and the workplace. Independent Sage has written and spoken about these topics extensively before, and we want to present to you with updated versions of those reports because these documents remain just as relevant today as they were this time last year. And as always, of course, all of those reports are available on the Independent Sage website. And then I'm going to hand over to Professor Robert West, who joins us today from the Independent Sage Behavioural Group, and he's going to give a presentation on COVID safety codes. So first then, over to you, Christina.
Thank you. So just say there will be a full numbers week next week. So it will come. This week, there isn't actually that much different to last week. So let me just share my screen. So I'm going to be talking about 2 documents that we did last year on safer schools and safer workplaces, and just kind of highlighting their relevance now. So this is a chart of cases per 100,000 people per week for school-age children, so 5 to 9-year-olds, 10 to 14-year-olds, and 15 to 19-year-olds, up to March this year. And you can see schools went back in September. There was a big increase. It gradually fell. This was half term, went up again. This was lockdown. And cases fell in the 15 to 19-year-olds, but stayed high and steady in school-age children because obviously schools were open last November. And then in December, when the Alpha variant started spreading, there were really, really large increases. Now, at the end of November last year, we released an urgent plan for safer schools because we were watching cases going up and we felt that something really needed to be done. Unfortunately, I would say most of the measures that we recommended were not implemented, and cases carried on increasing to December, and several schools had to shut early. And we know then, what happened in the peak, and then obviously schools were shut for several months. This is what's happened since. So cases in school-age children remained low in the spring, but once Delta took hold and the country opened up and cases went up, cases in school-age children really shot through the roof and were higher in all age groups by the end of July than they were in previous peaks. And since August, they have been going up again, particularly in 5 to 15-year-olds. So this is a situation as we go back into school now, and now we're going back with very few mitigations. So once again, we go back to that document that we wrote last November and think actually pretty much everything is still incredibly relevant. And so we're relaunching it with just literally one addition and a slight change in emphasis on ventilation. So these are the key measures that we recommended then and that we recommend again now. Distancing, it remains really important. And you can try and improve distancing through smaller class sizes, through staggered break times, staggered class times, and try and minimize contacts between classes. Ventilation is crucial. We now know that it is primarily airborne. So there are lots of things you can do to begin with, having carbon dioxide monitors, which help you monitor the quality of your ventilation. The government said they're going to roll it out. So far, no school has had them. But all they do is tell you if there's a problem. You then have to fix that problem, and you can do that through opening windows if that's possible, through mechanical ventilation as long as it's bringing in fresh air, or through air filtration if you can't do that, like HEPA filters. Masks remain a really important way you can mitigate spread. So I think we believe we should reinstate mask policies that we had in the spring. Bubbles are also important. This is part of distancing, of trying to keep groups of children together in small bubbles, not year groups. You don't want to be in a situation where a whole year group is mixing and then potentially you have to isolate, because we also believe that self-isolation remains really important with this disease, and that close contacts identified within schools should isolate and be supported to isolate. So that means supporting children to carry on learning at home. Testing is important, so not just the regular testing of students and staff, but particularly PCR tests of contacts, of all contacts, to try and find asymptomatic cases. Learning resources remain really important. We've been advocating for this for well over a year, but particularly for students from low-income families, there has to be support for home learning. There has to be support to allow children to have laptops and internet, and support for spaces in which they can study. Exams might be important again. If there is significant disruption to education this term, it's unlikely to hit all schools equally. And as we recommended last year, then it might be better to consider alternative arrangements again, that exams stop becoming fair when you know that students from different places have had different opportunities to learn. Well-being is important. We have to be able to enable young people to socialise safely. We have to think of creative ways of doing that. And we have to not fine children who are either clinically extremely vulnerable or live with clinically extremely vulnerable people for prioritising home learning in this situation. Transparency is really important. Clear information on policies, clear information on what the infection status is in your local school, communicating between staff, local authorities, parents and children. We advocated then and still believe that local public health teams are the main source of advice. And for staff, that clinically vulnerable staff should be enabled to work from home wherever possible so that they can reduce their exposure to this virus. And finally, and this is really the only new thing since last year, is vaccination. And we believe we should be rolling out vaccines to 12 to 15-year-olds as soon as possible. This is kind of complementary to a letter that was published in the BMJ today, which has many independent stage signatories on it, but really calling for safer schools. So we see this document, it's about 13 pages long. It provides really detailed advice on how to do it. So this is kind of the how-to for what needs to happen. And I just encourage everybody to go and watch the Emergency School Summit that was happened today at noon, because it's really, really powerful perspectives from abroad on the situation of schools and the situation that they're now seeing in Israel and the United States. So moving on to safer workspaces. So a year ago, this is where we were with the number of confirmed cases. We were about, less than 2,000 cases a day. And everyone, is similar to now, people coming back from holidays, schools are opening, people going back into the workplace. And we released this COVID safe workplace charter and briefing document that we believe will enable people to work, go back to work safely and try and keep transmission down. Now, this was produced in partnership with the Hazards Campaign, just as the education report was actually produced in partnership with the Eagle Research Group for Schools. It wasn't implemented, unfortunately. Now, I'm not saying that everything that happened since last September is because this wasn't implemented, but I have no doubt in my mind that if some of these measures had been implemented, we would have seen less severe peaks. This is the current Delta wave. It's now going up. We're now going into September and return to workplace at 30,000 cases a day, not 2,000 cases a day. So we believe, again, that if you go back to this charter, it's so relevant to what we're doing now. We're encouraging people to go back to work. We want the economy to open, but then we have to do it safely. So what the charter really sets out, and again, it is quite a lot of detail, but it sets out responsibilities for employers, for the health and safety executive, for local authorities and government to really support the co-development of what we've called a COVID safe plan for each workplace, working together with workers and trade union safety representatives. And the idea is that it sets up a framework for employers and workers and trade unions and safety executives to really make their workplaces as safe as possible, and then to have a regulatory framework that actually checks that places are as safe as possible and can do something about it if they are not. The only additional emphasis that we would now add is vaccination. So that's changed since a year ago. So we believe workplaces should be supporting vaccination through, e.g., arranging workplace vaccination, making sure people have paid time off to get their vaccine. and making sure people can have access to sick pay in case they have to take a day or two off work because of the short-term side effects. Again, ventilation is increasingly important. This means that all businesses and workplaces should have adequate means of monitoring ventilation levels and then addressing any problems if it turns out they're not well ventilated enough. And local authorities and central government should be putting in place mechanisms to support that kind of change. And finally, just changing the culture of presenteeism. I think we've all learned over the last 18 months that certainly not all kind of work, but some work can be done effectively from home. And we shouldn't now be saying to people, you have to be in the office just for the sake of it. So we should still think about, where can people work effectively from home? How can you do blended home working and office working? And then that also will help mitigate the transmission of this virus and in fact, other viruses. So that's all I really want to say about it. I would say, please go to Independent Sage website. Please look at these reports again. They are incredibly relevant, and we believe we should be looking at how to do this. And in a sense, the last year was a missed opportunity to really implement these kind of measures. And that's all from me.
Thank you very much, Christina. And I do think what's astonishing is that this report builds on reports that were published by Independent Sage last year. This is not new. We've had a long time to be making schools safer, and we're asking for the same mitigations. And in fact, what's happened is that mitigations have been reversed. So we're at a very strange time at the moment. We're now going to go to Professor Robert West, who's Professor Emeritus at UCL, and as I said, part of the behavioural subgroup of Independent Sage. Robert, thank you for joining us.
Thank you. I'll just share my screen. Hopefully everyone can see that. Yes, so it kind of builds on what Christine has just been saying. Now, SAGE and the behavioural subgroup of SAGE, back in April actually, wrote a report that was commissioned by the Cabinet Office on how to sustain behaviour change once the legal restrictions were lifted. And that report is available. And one of the key things that it identified was the need for a proactive risk management strategy. So it's really about implementing the kind of things that Christine has just been talking about and more in a way that actually should not be unfamiliar to people in many areas of business and government and society, because risk management strategies are very commonly used and have proved very effective. Now, one of the things that is very important about risk management strategies is that everyone involved shares some of the responsibility. In other words, what you identify are key actors, whether they're customers, whether they're staff, whether they're members of government, local government, and so on. So a key factor is that all sectors of society, in this case, since this is a national issue, in fact, an international issue, share responsibility. And as I say, codes of practice play a vital role in other areas. I used to work years ago in the area of road safety. And of course, we have the highway code, which is an important form of a code of practice, but there are codes of practice in other areas as well. And if you look at all those kinds of codes of practice, they do three things, really. They try to ensure that in that potentially risky scenario where you have to go about your business, you have to function, that the spaces are as safe as possible, and that you provide facilities to make sure that safety is ensured. Secondly, you make information and resources available and accessible. And then thirdly, you promote safe behavior through various mechanisms. So what we've done is to start the process of outlining what codes of practice might look like in four key areas. And I think I should stress at this stage that this is very much the beginning of a process. And the aim here is to co-produce these with everyone and anyone who has a stake in these issues, from members of the public all the way through to people working in local government and so on. So this is a start of a consultation process. I'll come back to that right at the end. And the 4 areas that we've looked at are local government, employers, public-facing businesses and services, and the general public. And as I say, this is a starting point for discussion. Now, we thought that it might be helpful when people are looking at these ideas for codes of practice to evaluate them using a framework that has been developed, and it's rather a long link at the bottom here, but people can sort of access it at leisure and type it in, or you can Google Achieving Behaviour Change, Public Health England, and you probably get it as well. But anyway, this framework is designed to provide a broad, as broad as possible way of evaluating interventions and things that you might try to do. And they focus on 5 key things. One is, how acceptable is it? And this is incredibly important because it has to be acceptable to all the people who will be involved, whether it's members of the public, staff, and so on. Second one is, how practicable is it? Is it going to work? Can you deliver this? Is this code of practice something will actually work in the real world? Thirdly, of course, how effective is it likely to be? It's all very well having things that you can do relatively easily, but if they won't make much difference, then is it worth really doing them? And then fourthly, affordability. Is this going to be, is it going to cost too much, whether it's to a business or to individuals or to local government or whatever? Fifthly, very importantly, what will be the spillover effects, the unintended consequences? They could be good in some cases, but very often they're bad. And of course, a lot of what we deal with in trying to address COVID issues is addressing them without ruining everyone's lives. So spillover effects are incredibly important to consider. And last but very much not least is equity. Is this going to increase or decrease social inequalities? So, of course, these 4 sectors that we're looking at overlap in a way. So we're all members of the public. So the one that addresses the public is really for everyone. But within that, we also have codes of practice that are directed specifically at local government. But local government are also employers. So many of the factors in the employer codes of practice will be relevant there. And of course, public-facing businesses similarly have very similar sort of issues to employers and local government. So the reason I raise that is that probably all 4 of the codes of practice will be relevant to quite a lot of sectors. So I'm just going to finish by giving a few examples from this, and the document is on the IndieSage website for you to have a look at. What each one starts with is, what is the overarching responsibility? And for local government, the overarching responsibility we suggested was to provide information, practical support and resources for people and organisations in their locality, and to ensure good practice as employers and ensure safe practices in all premises within their jurisdiction. And then you drill down from that onto a number of things, and I've really just summarised some of these. One is obviously providing information on local conditions, risk levels in the local environment, and the results of risk assessments that are being undertaken in local businesses and settings and so on. Ensuring ready access to vaccination and testing where it is within the gift of local government to do that, or to the extent it is. Undertaking and reporting on safety assessments in businesses and organisations and so on within the area, promoting COVID safe behaviours, both in their premises and on any transport that they might have responsibility for. And very importantly, and I know a lot of, well, almost all local authorities are doing this, providing support for mutual aid and community support groups. With regard to employers, we felt, at least in this initial stab, that the key thing was to ensure maximum COVID security for all employees, customers and visitors, which would involve following and disseminating best practice guidelines of the sort that Christina has been talking about, work with staff organisations to develop this COVID safety plan, create a supportive COVID safety culture. Culture is incredibly important when it comes to risk management, and that's very well demonstrated in a lot of areas. and implement flexible working from home arrangements where that's at all practical. Public-facing businesses and services, the responsibility there is to create as safe an environment as possible for everyone, staff, visitors, customers, and service users, clients, whatever it might be. Ensure that the premises adhere to COVID safety standards. Again, a culture of respect for COVID safe behaviours, and to dissuade people from attending if they have suspicious symptoms or if they think there may be an issue, and to raise the bar for people in terms of expectations about whether it would be right to come and visit or shop in this facility or use this facility if there's any doubt about symptoms, for example. To adapt their premises wherever possible to provide outdoor spaces. Obviously, in many cases it isn't, but where it is, to try and do that. And also it's been suggested to provide sessions for vulnerable users which have heightened levels of risk management in place. And then finally, the public. And there's loads of stuff to draw on here, from the WHO and through to other organizations. But the key responsibility is to keep oneself and one's contacts as safe as possible. And that means taking up vaccines and boosters when offered, self-isolating when required, adopting COVID-safe behaviours. This is all very familiar to people, I imagine, and supporting others to meet the challenges. I think that's a key aspect that sometimes gets neglected. So next steps is we plan to engage with relevant groups, and do please contact us with suggestions if there's anyone you think we ought to be talking to about this. And then people don't have to use it, but to encourage people, if they want to use the APPEASE criteria or something similar to structure their evaluation so that we can get these outline codes of practice right, and so that they can be elaborated in the way that needs to, in terms of clarification, examples, and so on, and then to go on to develop and publish this with an implementation plan. Now, it's really important to say, obviously, that this is not IndieSage. This is not something that IndieSage should be doing in terms of making this happen, making these codes of practice work and so on. It's something that our job is to facilitate and support and help with as far as we can. And if you have any comments or suggestions, then the email to address those to is on this slide. And I will stop there. Thank you very much.
Thank you very much indeed, Robert, and some amazingly useful, practical advice coming through that as well. And as you said, that's available on the website. Right, time for some questions, and we'll start with Bianca Herbert. Bianca, are you with us? And what's your question?
Yes, I am. Thank you. Thank you for inviting me. We deregistered our children last year, and they have been home educated since then. And we currently only socialize with other children outdoors. My children are both 7, and they don't have any underlying health conditions. My husband and I, we are both fully vaccinated, but I have chemical sensitivities, and there is medication that I am reacting to, and it could be a little more tricky if I would need treatment. So our old school is a primary school, and neither staff or children are wearing face masks. But I do believe they keep their classroom windows open. There are no bubbles, and approximately 30 children in a very small classroom. And I hear very conflicting information now on how COVID affects children, from they only get it very mildly to cases are rising, and 1 in 7 children has long COVID. So my question to you all is, what are the pros and cons of sending my children back to school? And when is the right time? What data do we base our decision on? And how likely is it that we then catch COVID? How likely is it then when my children catch COVID that I will get ill, will get seriously ill, will need treatment? And yeah, what would you do in our circumstances? Thank you.
Thank you very much, Bianca. I think it's completely understandable, the decision that you've made. Obviously, Independent Sage can't offer individual advice, but what we can do is look at the bigger picture and talk through some of the issues that you've just raised there. And a lot of us have just come we've just come from a previous meeting, an emergency summit on schools and child's health, where we were talking about some of these issues. So I wonder if I could ask Professor Anthony Costello to start with this. Anthony, you were at the emergency summit this morning as well.
Yes, gosh, this is such a difficult question. And I think parents up and down the country are facing your kind of concerns and dilemmas. We're in, as somebody said in the meeting, we're almost in a different pandemic now from the one we had last year, because we've got this Delta virus, which is much more transmissible. And it also it's difficult for people to guarantee that if you're vaccinated, that you don't actually get infected as well, as several of us have found out, that you can get infected when you're vaccinated. But of course, vaccination does protect you from the serious consequences and dramatically reduces your risks of hospitalization and death. Now, on children by and large, the younger they are, do generally get a very mild infection. Having said that, the facts and figures that came out in the meeting earlier today are that we are currently seeing, we've had about 2,500 hospitalizations over the past 2 months. Death rates are extremely low, but there have been some casualties, and there have been children who have developed a condition called multi-inflammatory syndrome, usually in older children, and it is extremely rare. But you are right. The bigger concern is the risk of getting a long COVID type problem. And there are various statistics, but a lot of people now think it's about 1 in 7 children who get infected will have persisting symptoms of some kind or other. Now, obviously, it's very important for children to get back into a school environment, because it's good for their social education, for their formal education. And we all want that to happen. And with decent ventilation, and ideally with access to vaccination down to the age of 12, then we would be confident children are being protected. The big question, of course, is why the UK, almost alone amongst wealthy nations, is not rolling out vaccine below the age of 16. And that was the big discussion that we had this morning. Maybe we could come back to that later in this question and answer session. But it is a difficult challenge. And, fortunately, my children are in their 20s and early 30s now, so I don't have this dilemma. I think, Alice, you've got children going to school. Are you equally nervous? What's your own view? Sorry, I shouldn't ask you a question, should I?
No, you can, of course. I mean, yeah, I am nervous about it, because we are in a situation where we're sending our children back into schools where there are, as Bianca said, very few mitigations in place, and still actually a real focus on cleaning of surfaces and hand washing, which is great. But this is an airborne virus, and so we also need to have attention paid, as we've heard this morning, to aspects such as ventilation. And we don't have any mask wearing, and we've never had any mask wearing in primary schools. So there does seem to be a huge gap. Gavin Williamson was speaking in the media yesterday and saying that actually it was fine because primary schools were being given carbon dioxide monitors. Now, they haven't been given them yet. The plan is to roll those out, and we don't think there's enough for one in every classroom. And also the carbon dioxide monitors are just there to monitor. What we hope is that means that what flows from that is a responsibility to achieve certain standards of ventilation, and there needs to be investment in that. And at the moment, all schools can do, as Bianca said, is open the windows. So we've got a situation where we know that cases are 26 times higher than they were this time last year, that the mitigations that are there in school are less than they were this time last year. And we also don't have any vaccination of under 16s happening in the UK. So I think it is a worrying time for everybody. And although schools are testing with lateral flow device tests, the uptake on that was dropping off significantly last summer. So I hope there'll be greater uptake of that, but that's our only hope at the moment. Zayamdel, can I bring you in as well, because this is an issue of inequality as well. Different people are going to be affected differently. We know that the pandemic has already deepened inequalities in our society. So I wonder if you could speak to that.
Well, yes, because I think, I mean, actually, Alice, you raise some really important points. Firstly, that when, schools are not in a vacuum. When you've got extremely high cases, and we've got above 30,000 daily cases right now in comparison to last September when it was around 1,000, that means that means that you're going to get surges in schools. But as Alice rightly points out, we also need to keep in mind who the school population are. And we know that approximately 1 in 3 primary school children and 1 in 4 secondary school children are from Black and ethnic minority backgrounds. We saw data recently showing that I think around 1 in 3 ICU admissions, or 1 in 4, I'm not sure, 1 in 4 and 1 in 3 ICU admissions are people from Black and ethnic minority backgrounds. So this pandemic does have an unequal impact. We know Black and ethnic minority children, because of the circumstances that they live in, more likely to be from disadvantaged areas, more likely to be from overcrowded homes, are going to be exposed to this virus. And in that sense, it is very, very worrying. Now, one of the things we talked about at the summit just before Independent Sage briefing today, and it was a summit looking at children, Delta and schools, is that there are some things that could be done straight away. Face masks need to be reinstated. Now, that's not likely to be done in primary school, so that won't help you enormously. But contact tracing, physical distancing, those issues could be done immediately. They need to be done immediately right now. And at the moment, we have an extraordinary situation with contact tracing where if a child is in a house where someone is positive, they can still be sent back into the school. Now, that's quite shocking, and that goes against everything we've learned in terms of public health safety in this pandemic. So that needs to be scrapped. We need to reinstate contact tracing, reinstate bubbles, absolutely have ventilation, but that's going to take a while. But do the contact tracing, have bubbles up again, and do a bit more to ensure that there is proper airflow in schools.
Alice, could I just add one thing for reassurance, that the vast majority of children in primary school do get either no symptoms or a very mild infection. And the reason for that is because they have many fewer receptors in their body for this virus, and they have better means of what's called natural immunity. So, the vast odds are that the younger the child, and that's why they haven't anywhere come up with a vaccination plan for under 12s yet. But so the risks to primary school children, despite everything we've said, are extremely low.
Thank you very much, Anthony. Bianca, thank you very much for your question. Thank you for joining us today. Sarah Zayamdel is joining us. Sarah, are you there? And are you able to ask your question?
Yes, thank you very much for this chance to ask this question. My question is about the start of the academic year in universities, and that we see many universities are following the learn to live with COVID rhetoric with very few or no provisions in terms of distancing, ventilation, or vaccination. For example, we are told we have to conduct induction sessions in mid-September with student groups as big as 250 in one room, involving interactive elements with no obligation for mask wearing. So without the necessary mitigation measures in place, how can we avoid breakouts? What do you think needs to be done in terms of interventions? Thank you.
Thank you for that question, Sarah. So thinking about tertiary education, then how should universities and colleges be approaching this? It's a very different question, isn't it, for universities and colleges, because we are looking at a population which is largely vaccinated now, or is partially vaccinated compared with school children. Christina, you'd like to answer this one?
Yeah, well, actually, I just wanted to say that next week we're launching our universities report. So we also did a universities report a year ago. We have comprehensively updated that now for this year. and we're launching it next week, where it goes into what universities can and should be doing to mitigate COVID risk transmission as students come back this month. So I kind of don't want to preempt it, and also because I haven't led that report, so I'm not the best person to comment exactly on it, but Susan might be.
Susan looks like she wants to come in here.
Absolutely. I mean, next week we will probably go into it, but just to remind everybody that universities are workplaces, and lecturers, research staff are workers, but also universities have a duty of care, not just their teaching and research staff, but all the staff that make a university work, administrative staff, domestic staff, maintenance staff. So I think all of the points that Christina went through to do with workplaces and the codes of practice that Robert went through are relevant. Over and above that, there are obviously some things that are specific to universities, which we will address next week.
Thank you very much, Sarah. I hope you can join us again next week when that report will be presented. Thank you very much for that, Susan. And we have the generic guidelines for workplaces at the moment, and something a little bit more university focused coming next week. Right then, I think I've got a question from Mikey Smith of the Daily Mirror. Mikey, are you there?
I am here. Yes, can you hear me okay?
Yes, we can. Go ahead.
So one thing we're looking into this week is availability of jabs for 16 and 17-year-olds. We're seeing reports that there is something of a, you could call it a postcode lottery, where teenagers, under 18s, are being directed to walk-in centres rather than being able to book in every vaccination centre. And in many cases, that is sort of 2 towns away, long bus rides, as parents are sort of quite desperate to get their kids vaccinated before going back to school. Is that something you're aware of? Is that something that you could comment on? Any changes need to be made? Is there a reason why 16 and 17-year-olds are being directed to walk-ins as opposed to they're being directed to specific walk-ins as opposed to being able to book through the major vaccination centres? Anything you could tell me about that would be great.
Thank you very much, Mikey. Helen, I wondered if this is something that you would like to respond to or can inform us about.
I'm afraid I don't have an answer to your question. Certainly in the area that I'm in, there are a lot of different walk-ins set up for the 17 to 18-year-olds, I guess on the kind of assumption that they're more likely to come if they can just, as they're advertising it, grab a jab. But I hadn't heard that they've been excluded from the other provision. And I think while we're talking about all the other mitigations that we might have and what we can do to keep people safe, the thing that one of the major things we do is make jabs easily available. And there's quite a lot of talk about how you would incentivize people to be vaccinated and whether there should be sanctions if you're not vaccinated in terms of what you can access and what you can't. But I think one of the main ways of helping people is just make it really easily available and really, really well publicized so that everybody knows where they can get it, when they can get it. Because I think that's going to be the thing that's going to make us safest, is that everybody who wants to get jab can get it somewhere convenient and easy. And I hadn't heard that there was this problem, Mikey, but if there is, that clearly makes no sense at all, does it? We really want all of everybody who's eligible to have a vaccine to have it as soon as possible, because they make such a difference, certainly to how many people get really sick and also to the amount of virus that's circulating.
Thanks.
Thank you very much, Helen. Dr. Helen Salisbury is a GP and educator. Helen, are GPs involved with the rollout to 16 and 17-year-olds as well then?
Mostly we're not. There may be a few that are, certainly where I am, we did a lot of work with the much older age groups, but we had to just get back to our normal work when it came to the younger people, because we just don't have the capacity to do the vaccination for the younger people as well. We're in a slightly difficult situation at the moment because we're expecting there to be a booster program, but it still hasn't been announced officially. And we would love to be able to get on and organise, but we're forever doing things with 5 minutes notice. It's getting quite hard.
They'll let you know the day before.
Yeah, absolutely, and expect us to get on with it.
Professor Martin McKee, you'd like to come in here as well.
Yeah, thanks very much. I think you might want to look at a statement by Dr. Camilla Kingdom, who's the president of the Royal College of Paediatrics and Child Health. That's on their website, which thanks the JCVI for their hard work, but then says, and I quote, that while the programme for adults has been incredibly impressive, but for children and young people, it has been frankly shambolic. Once again, paediatricians have been left completely in the dark. And I think that's probably worth referring to, because it does indicate that there was a problem with the planning of the rollout. And it does, what you're saying reflects very much what some of us have been hearing as well.
Thank you very much, Martin. Anthony, you'd like to come in?
Yeah, just very quickly. One issue, of course, is we've been pushing for this, is because it does take time once you get your jab for you to become, get a decent antibody response and become immune. In fact, when you look at some of the papers from the New England Journal, the encouraging thing is that although officially, it takes 3 weeks to get a full response after you've been jabbed, in fact, you get a decent amount of protection even after a week. So my advice would be to any young person in the 16-17 group, even if it means getting a bus or a train, go and get your jab, because in a week's time, you will have some protection there that will then grow over time and will give you, that little boost. And then hopefully you can go on and get a second jab at a later stage.
Thank you very much, Anthony. Mikey, thanks very much for the question. Moving on to another question coming from Martin Shaw. Martin, what's your question for us?
Hello, Alice. My question is this. Over the last year, we've got used to socialising and mixing, doing our social activities outdoors. And I understand that with the Delta variant, it's still much safer to do things outdoors and indoors. But I have noticed more reports of transmission of COVID outdoors than previously. And I noticed that the public health spokesman in Melbourne, Australia, made a point of emphasising the problem of outdoor transmission when he was giving advice to the population there. So I wonder, first of all, what's your take on the evidence in this area? How do you evaluate this problem? And secondly, what kind of advice would you give on this now in the light of what we know at the moment?
Thank you very much, Martin. Professor Deenan Pillay, I wonder if I could bring you in here to talk about how this virus operates and whether we should be concerned about outdoors transmission.
Sure, thanks, Martin, for the question, and it's a very, very pertinent one. Of course, we should preface this by thinking of relative safety. So there's no absolute safety with this virus. All we can do is try as much as possible to limit transmission. And that is why outdoors, we've always said, and as of many authorities, that being outdoors reduces the chances of what is an aerosol, a virus that is breathed out as the infectious virus. It reduces the risk of transmission, but it's not all or nothing. And of course, the more infectious a virus is, then the more those chance encounters will increase the risk that you will be infected. So it is that's to start with. These are all relative questions, and we know the Delta virus is far more infectious. That's very, very clear. Having said that, we would still say, as do many people, that being outdoors very significantly reduces chances of transmission. But one of the things that has led to is the feeling of outdoor events, rather than walking outdoors by yourself or with a small group of individuals. And of course, outdoor events have a lot of other things associated with them. They have the transport to that outdoor event, whether it's a sporting event, it's a music event, or any other sort of event. It is it's travel. It's using toilets. It's queuing up at bars. It's all of those things that will also increase the risk. And of course, close proximity. And as I think one of my colleagues said last time, even if two of you are outdoors, if one of you laughs in the other person's face, or shouts, then clearly the risks for that as an individual risk is increased if that individual is infected. So these are all relative issues. I'll just stress again that the risk outdoors is much smaller, but of course we've got to think of all the other things that go along with outdoor, particularly large events where large numbers of people come together. And this goes back to the documents that were very well presented by both Christina and Robert earlier, about the sort of responsibilities we have, employers have, public health, local government have, for ensuring that facilities, even outdoor facilities, are safe in that respect.
Thank you very much, Dean, and Professor Martin McKee, over to you. You'd like to say something?
Oh, yes, sorry. I think the Australian, why they've been saying that in Australia is that they've had a number of very well documented cases, one in particular where they had closed circuit TV that was able to look at the individual who was infected and the person who became infected, and they had a very transient passage by one another. So I think that's been what's shaped that. Clearly with Delta, as we've heard, it is a more infectious variant. So you are getting a greater risk, but as Dina has said, it's not an all or nothing thing. It's just that it's a relative thing.
Thank you very much, Martin. Robert?
Yeah, just to develop that idea, I think that we're now in a situation where people need to be able to make informed judgments in terms of their own risk management. So there will be occasions where you have no choice about going into an environment that carries a certain level of risk, and the only discretion you have is how you operate in that environment. But there are other cases, particularly leisure activities and so on, where you make a decision about what you think the level of risk is, and that decision should be able to be as informed as possible. And in that decision, the information is, what is the level of infection likely to be in the environment in which you're operating? What does the space look like? What does the ventilation look like, and so on? And it may well be, and I certainly make these kinds of decisions, that I would decide not to go into that situation. Even if it's outdoors, I would say, well, no, I'm sorry. That's not a risk I'm willing to take. Someone else may make a different decision on the same information. But the key, I think, is that if we're going to make informed decisions, we have to have the information. And that is a big gap, I think, still in terms of empowering people to do their own risk management.
Thank you very much, Robert, and the other responders there. Thank you very much, Martin, for your question. We've got a question now from Julia Garlick. Julia. If she's here with us. Oh, I can't actually see Julia here on my screen. Julia, if you are here, we might try and squeeze you in a bit later. I'm going to go then to Hannah Hassan. Hannah.
Hi there, thanks. So it seems like the views of Independent Sage and other campaign groups like Zero COVID are scarcely being discussed in mainstream media and social circles. If journalists and politicians see these views as marginal and encourage learning to live with the virus, then what's the likelihood of policy changes being discussed or even considered by the UK and devolved parliaments?
Thank you very much, Hannah. Over to you, Robert.
Well, I'm very gratified to be able to tell you that the information that I have is that contrary to what's happening with the Westminster government, the devolved governments, particularly Scotland and Wales, are very attentive to not just Indie Sage, but to all those experts and scientists who are trying to provide the best evidence-based advice. And sometimes, I participate in a subgroup of SAGE as well. It feels like, you're really banging your head against a brick wall when it comes to the Westminster government. But it's very gratifying and reassuring to hear from colleagues in other devolved governments that actually they really welcome and use the sort of advice that not just us, but others who take an interest in these things are providing.
Thank you very much, Robert. I mean, there may be an intimation that that Westminster is listening a bit. I mean, certainly with the promise of carbon dioxide monitors to schools, I think those kind of, that's come through. Even if they haven't got as far as actually implementing a better ventilation. Martin.
It's important to remember there are three branches of government: the executive, the legislature, and the judiciary. And while the executive in the UK may not be, or in England anyway, may not be listening, I think the legislature certainly is. And many of us have given evidence on a number of occasions to the all-party parliamentary group on coronavirus and to select committees, and also offline to members of parliament of all parties. And this is actually an all-party thing. It's not a party political thing, although there are some people who would represent it that way, but it absolutely is not. So I think that within the chamber of the chambers of both houses, these views are definitely being heard. But like so many other things, there's a question about the gap between the executive and the legislature in this country.
So, Martin, are you broadly optimistic then? I mean, Hannah's question sounded a note of pessimism there, but are you broadly optimistic about policy that actually does follow the science then?
Well, I'm in a very fortunate position in that most of my work is outside the United Kingdom. So therefore, I'm engaging with G20 and with other governments. I do advise a number of other European governments. And from that point of view, I'm really quite optimistic. I've just actually come from a meeting in Geneva yesterday where we were discussing many of these issues. And I think the views that we're representing on Independent Sage are definitely informing decisions at a European and a global level. So from my point of view, the news is good, but I do share the concern about what's happening in the executive in Westminster.
Deenan.
Thanks, Hannah, for the question. It's very pertinent at the moment, and I agree that to some extent, a group such as ourselves, Independent Sage, as well as others, have been put into a box, at the zero COVID box, where the response has been, well, of course, that's pie in the sky. We've got to live with the virus and so on. But as you've heard earlier for this press briefing, is that there are very specific things that can be done, many things that can be done to minimize infection while still not arguing for lockdown, which is, of course, the way that we're often characterized. And we're not saying that. We actually don't want any more lockdowns. And we're not blessed with leadership in the executive in the UK, particularly in the Department of Education. If you heard Gavin Williamson's recent discussions about CO2 monitors and the lack of. But these are issues that are clearly coming up. The fact that schools are having to now think about, and government is starting to think about how to monitor ventilation is relatively new. And we've been arguing for this within Independent Sage for more than a year. Schools documents going back a year have done that. And the fact that this is now on the agenda, I think does demonstrate that there is a space for us to campaign in to actually make the environment as safe as possible that we can open up as. So I would not be negative about this. I would say that the next few months are critical in terms of how all the devolved nations, but particularly the more intransigent English administration can actually start to provide leadership that will allow us to continue our life whilst minimising infections.
Thank you very much, Dean, and Hannah, thank you very much for your question. And now I'd like to invite a question from Stephen Corder. Stephen, are you with us?
I am. Thank you very much for taking my question. Yesterday it was reported in the mainstream media that Public Health England is insisting that schools are not the drivers and not the hubs for COVID infection. Is that correct?
Thank you very much, Stephen. It's it is confusing, isn't it? Because on the one hand they say that schools aren't hubs for COVID infection, and yet on the other hand they say they're fully expecting a surge as soon as they open. Christina?
So I think it's a bit disingenuous what they're basically trying to encourage people that there's not an issue when schools go back, when there is an issue, right? And it's not that schools are worse than other indoor places. They're not worse than them, but they are an indoor place. And they're an indoor place that often has poor ventilation, that does have crowding, and that now has the single population that is the least vaccinated. So that means that if you're going to pick somewhere where COVID's going to spread with Delta, it's going to be in a school. It doesn't mean that they're driving transmission or that they're like super spreading places, but that is where the issue is right now. And we will see that, and we have seen that when schools have gone back in other countries, and I'm sure we'll see it this September as SAGE warned a few weeks ago that they're expecting significant increases in cases in children. And so the question is, why are we not putting in the mitigations that can help prevent those spikes? You know, things like masks, like social distancing, like keeping in some bubbles, like improving ventilation. You know, we've had so long to do that, especially on ventilation, and we just haven't. And, you know, so I think trying to say that they're not hubs of infection is a way of kind of avoiding the question of why not more hasn't been done to keep them safe. And sometimes people say things like, well, you know, there's no time to implement those kind of measures. They're long-term measures. I'm like, okay, well, then we point to the fact that people have been asking, and we're not the only ones, trade unions, other organizations have been asking for these for a year. And if you keep saying there's no time, then there won't be, you know, by definition, because you're not doing anything about it. So that is my view on it.
Thank you very much, Christina. Susan?
One of the things about schools is that people spend many, many hours together every day in close quarters, and often children are really quite close to each other. And I mean, Dina can correct me if I'm wrong, but my understanding is that at least 40% of children who are infected aren't symptomatic. And so schools can play what's being referred to as a kind of amplifying function, where infection comes in from outside, it spreads around within the schools, and then children take it back out to quite a wide variety, sometimes of different communities. So it's not just about the what happens in school, but it's the prevalence outside that's really important, because that makes it more likely that the infections are likely to come into schools and then spread around.
Thank you very much, Susan. I mean, it does seem it is disingenuous, isn't it? And to suggest that there is no transmission happening in schools, and we've heard this again and again and again over the course of the pandemic. Yet, while we've had SAGE scientists like John Edmonds telling us that the primary route of infections into households last autumn was school children. That message is obfuscated. So we're going to move on and have one last question, and it comes from Kate Edgar. Kate.
Hello, thank you for putting me in. My question is about young people and vaccination. I've had long COVID for 11 months now, and despite the huge effect that this has had on me and my family, my 18-year-old son refuses to get vaccinated. His argument is that because both of his parents have been vaccinated, he doesn't need to be. He also caught COVID last year and believes that the risks from the vaccine far outweigh the dangers of the illness for him. Finally, he feels he's being coerced by the government to do something that's not in his best interests. As scientists ourselves, we find his stance frustrating and depressing. He's an intelligent young man who hopes to go to university next year. So my question is, why are some young people refusing to get vaccinated? And what does the panel think we can do to engage them in the importance of this? Thank you.
Thank you very much, Kate. And it sounds like you're having conversations with him, and I think that listening is incredibly important to try to understand what his concerns are, and then to share data with him. But could somebody from the panel pick up on this, please? Anthony.
Yeah, no, it's fair enough. He's obviously a free thinker and somebody who has views. I think what one does in conversations with people like your son is to present the evidence. And I think there have been very mixed messages coming out from many people saying, oh, children are completely fine, they're very low risk, there's no problem. So the facts are, when they looked at the first year of this whole virus, and they looked at all the data in the UK up until about February this year, there were just under 6,000 people who ended up in hospital. There were 250 who ended up in intensive care, about 2 or 3 times that number who had this multi-system disease, which does lead on to problems. And there were 25 deaths of children from COVID and 61 deaths from older children who were with COVID, but probably died from other reasons. So just when I look at those figures, and clearly they will have pretty much doubled since then because we've had the Delta, that's not a trivial issue. It's not huge, but it's not trivial. But then you add in the whole risks of long COVID, which is now thought to affect 1 in 7 of children who get infected to some degree. And as somebody who, I was double vaccinated, I caught a breakthrough infection and I have developed long COVID symptoms over the last 2 months. And it's not pleasant. You get fatigue, you get tingling, you get loss of smell. And there are broader concerns about long COVID, and we don't want to scare lots of people unnecessarily. But we do need to think about, this is a virus that affects the brain, or the immune response affects the brain. So we have to weigh all those things up and follow people up over a long period of time to know what the longer term effects are. And when he says that the risks of vaccination are greater than the illness, I'm afraid he's completely wrong. All the figures show, whether it's looking at dropping your platelets or having a stroke or having a heart attack or having myocarditis, a very few children who get the vaccine do get some inflammation of the heart, which is short-lived, but much greater numbers get this from the infection itself. So I would argue to him, look, if you take the vaccine, you're going to reduce your risk compared to just sitting and waiting to get the virus. You are probably increasing your risk of long COVID. It makes sense to do this, but you're 18. It's your decision. You're not being coerced to have the vaccine. But I think it should be offered to children and to parents and to children down to the age of 12.
Thank you very much indeed, Anthony. And in the chat, I've just shared the cost-benefit analysis recently published on vaccinating adolescents, of which many of the co-authors are here on the panel. So we hope that might be useful as well. Thank you very much for your question.
Thank you very much.
And I hope that helps. We are going to have to wrap it up there. Thank you very much to Professor Pargle and Professor West for their very informative presentations at the top of today's briefing. Thank you all the scientists who are here to share their expertise with the press and the public. The 3 documents presented today are available on the Independent Sage website, along with all the reports that have been published over the course of the pandemic, but those are the most up-to-date ones. So please refer to them for any guidance that you might need. Please continue to send us your questions and tune in every Friday at 1:30. Do follow us on Twitter and Instagram if you don't already. Until next week, stay safe, keep well.
Bye.
Thank you. Bye-bye.
So much.